I think cesarean section itself is an independent risk factor for postpartum hemorrhage. As we are doing more and more cesarean, we find that this problem is increasingly become more prevalent. As you know, if you analyze all deliveries, the atonic PPH do have a preponderance, nearly 70 to 80%, whereas when you come to cesarean section, the traumatic component increases. Nearly 50% are due to the trauma and 50% atonic. And the fundamental approach to atonic PPH during cesarean section is quite similar to the vaginal delivery, which has been highlighted by the previous speakers. One of prevention, employing all the steps of AMTSL, then early recognition, excluding other causes such as trauma, then supplementary dose of oxytocin to improve the contraction. Then if there is an ongoing bleeding, then go on to the other measures. I think one of the cardinal rule is anticipate, be prepared for any eventuality whenever you are doing a cesarean section. And especially you'll have to be careful when you're doing an emergency section, and in case of over-distended uterus and conditions such as preterm pregnancy where the lower segment may be quite narrow. Then intrapartum sepsis and antepartum hemorrhage will have to be again very careful. I don't know whether it is appropriate to mention about the PPH box and ORT, because all these things are superfluous in the theater setup. Are we at an advantage in a cesarean delivery to tackle a PPH? I think yes, because patient is already on the table, anesthetized and monitored continuously. There is one anesthetist there, fluid drugs, everything is available. And should an emergency arise, I think we can just escalate the procedure into the next step. So there are advantages, but these luxuries may not be available in the labor room when you are dealing with an ordinary case of PPH where ORT is of paramount importance. But we'll have to balance these potential advantages with the disadvantages, because most of these emergencies, yes, at odd hours, junior staff doing the cesarean section, the element of fatigue, inexperience, all those come into play. Then the inherent problems with the type of cesarean, effective anesthesia. So all these potential disadvantages will have to be very careful. And I'm not overemphasizing on that. The currently practiced KFOG protocol is relevant for the cesarean section, also the classical 5 units of oxytocin. Then in the intravenous strip, I would prefer to recommend 20 units, because here a little more oxytocin may be necessary. And in all the studies done after the introduction of this protocol, we find that the blood loss has been considerably reduced, then transfusion, HDU admission, all the complications. And we aim at two things, that is by the bolus, a sudden contraction, and by continuous IV administration, a sustained contraction. If you can achieve this for about, in all cases, I think the acute placental separation and bleeding can be minimized. And we are conducting periodic audit. We find that in vaginal delivery, nearly 98% women, the blood loss is well below 300, whereas in cesarean section, 89% it is less than 500, with a median blood loss of 215 and 385 ml. That is well within the normal range. Again, I'm not going into the details because already this has been highlighted, but only thing is that I would like to highlight on the tranexamic acid, even though it is recommended in all cases, I think a word of caution, because it's a lookalike drug and a couple of instances of maternal problems have been identified when an inadvertent drug administration has occurred. So be careful and prepared for this to avoid such a complication. And if the atonia continues in spite of all the classical management, I think it is better to externalize the uterus. Bimanual compression can be effectively given and continue with additional doses of oxytocin. And if the condition is not responding, you may have to go in for a devascularization or some of the compression sutures. And if the bleeding is profuse, probably even in this situation, apart from the aorta compression and aorta clamp may be of help. And I should say that every obstetrician should be familiar with this fundamental approach, that is a uterine artery ligation, bilateral uterine artery ligation, and along with that, the utero-ovarian artery ligation, anastomotic branches. So by doing a bilateral urinary ligation and the anastomotic channels, we can find that nearly 70 to 80% of the blood supply to the uterus can be cut off. And there could be, most of these cases, no respond. Only thing is that when you place the urinary ligature, it should be about 1.5 to 2 centimeter below the incision site. Otherwise, what will happen is that many of the branches may escape and the bleeding may continue. And it is better to take a biomaterial bite also along with that, and any suture material may be of use. And if the bleeding continues, then probably apart from the stepwise the vascularization, we may have to go in for the other thing, the classical B-Lynch or any of its modification, or internal iliac artery or hysterectomy in due course. And whenever you think of the brace sutures, I think we should not forget about the B-Lynch, even though it is now the preference is for the Hayman because it is less cumbersome, very easy to perform. A pair of vertical compression sutures pass from the anterior to posterior and tied at the fundus. So anybody with minimal expertise can practice this, and the results are almost, I think, equal to that of B-Lynch. Easy to perform and no need to open into the uterus. The uterine artery blood supply is preserved and there is no need for a bladder dissection. But I'm afraid that in the so-called lower segment type of bleeding, this may not be useful, in which case probably I think something like a Cho's suture in the lower uterine segment may be much better than the conventional B-Lynch or the Hayman suture. I'm not going into the details because there is another session, but most of these internal iliac artery ligation is useful in traumatic PPH rather than in the atonic PPH. I think whenever you are tackling hemorrhage, I think instead of looking into single entity, it is always better to go in for a hemorrhage safety bundles. All these things should be coupled: readiness, recognition, response, and reporting. And there should be periodic drills and training to sharpen the skills of the doctors. Then only, I think, in case of an emergency, the output can be optimal. I think at the end of the day, there'll be a sigh of relief when you are successfully managed. Or you may think that you have saved a patient. That is right. But at the same time, we forget another important thing, that is, we have to debrief the woman and the family, because a rapid succession of events has happened in the theater and the patient is already anesthetized. And even least expected things would have happened. Even a hysterectomy would have happened in a private, will not know. But she needs, the family needs, one needs explanation when she recovers from the anesthesia. And this is highly necessary to minimize litigation along with proper documentation. So each near-miss cases can be a potential litigant. And thank you, and see you during the discussion. Thank you very much.